Good day to everyone and welcome to this webinar. My name is Dr. Tom Madayag, and our topic for today is complex arrhythmias. This is the second part. We did part one 2 weeks ago. Again, my name is Dr. Tom Madayag, and I am a professor at Broward College and also a guest lecturer and faculty for MedPro-U. Before we begin, I'd like to ask you to make sure that you raise your questions whenever you do have one. And there are two ways that you can raise your questions. The first one is for you to write the question in the chat box. And the second will be to raise your hand indicated or using the feature on the Zoom. And of course, you can always unmute yourself and then raise your questions. In addition to that, I'd like for you to know that the PowerPoint presentation is going to be loaded into Canvas as well as the video recording of this webinar. And it will be made available to you several hours after the conclusion of this webinar. In addition to that, I'd like to ask your participation in a game that we're going to have at the end of the lecture, and that is using the application called Kahoot.it. You're going to be asked to log into your phones or other devices, and you're going to answer the questions. And the objective of that particular game is for you to answer as quickly as possible. All right? So with that housekeeping in mind, we're going to go ahead and proceed. And welcome to everyone. And as you could see, there are several participants from all over the world. And of course, we welcome each one of you. So let me just begin with the presentation. Okay. Okay, so welcome everyone once again, and let's go ahead and get started. Could you please answer what you see? Okay, some of you answered atrial fibrillation, some of you answered atrial flutter, and some of you answered junctional tachycardia. So let's go ahead and look at the correct answer. The correct answer here is it's atrial fibrillation. So just as a review, in atrial fibrillation, there's this characteristic sawtooth pattern, and it is going to be the primary characteristic of atrial flutter. The treatment for atrial flutter is similar to atrial fibrillation. So one of the major concerns that we have whenever we have atrial flutter is going to be the possibility that blood clots may form. And therefore, the major complication that we think of is going to be a cerebrovascular accident, or CVA. Now, whenever you have, therefore, a patient with atrial flutter, we always want to think of the treatment to include not only to address the cardiac problem, meaning to say regularize the atrial contractions, but also to prevent thromboembolic phenomenon. And therefore, usually these individuals will receive an anticoagulation of some sort. Okay, so that was a simple one. And of course, I wanted to make sure that we have a basic understanding of the basic arrhythmias, and that's why this serves as a teaser to see whether or not you actually remember atrial flutter. So before we begin, I wanted to ask you these questions. How many times have you joined the webinar so that I would know how to address or go about with the lecture? All right, so there's 3 of you that are actually the first timers in this particular webinar. So we welcome you. Of course, we're going to make sure that we're going to explain to you as necessary. So the next question that I want to ask is if you were able to attend the first arrhythmia or complex arrhythmia webinar. Okay, it's 50-50, all right? Some of you attended the first part and some of you didn't attend the first part. So that's okay. We're going to go ahead anyway and explain like you have not attended it before. Okay, so let's go ahead and get started. Oop. Okay, so we're going to review pacemakers. A lot of you answered correctly that this is loss of sensing. Whenever you have an ECG strip and you see a vertical line such as this one, this is a manifestation that we have a pacemaker. In this particular instance, what's being pointed at right here is the presence of a ventricular pacemaker. And the reason that we know that it's a ventricular pacemaker is because the pacing spike, which is this, is followed by a QRS complex. So having said that, there are several problems that you might encounter whenever you have a pacemaker. And one of those particular problems that you would encounter when you have a pacemaker is what is known as loss of capture, and the other one is loss of sensing. Loss of capture is the presence of a spike that is not followed by a QRS. And this is usually as a result of either a decrease in the amperage that is delivered to cardiac muscle, and therefore the cardiac muscle does not respond. And therefore, it will not cause a QRS complex. The second problem that we have whenever we have a pacemaker is what is known as loss of sensing. Sensing is the capability of the pacemaker to determine and detect the presence of natural beats. So, like for example, what I'm pointing out over here, Can you see my pointer? Let me just change my pointer. These beats right over here are natural beats. So in the presence of a natural beat and a good rate, the pacemaker should not fire. But in this particular instance, as you could see, the pacemaker fired. It fired inappropriately, and therefore the problem is the inability of the pacemaker to detect or interpret this as a inherent or natural beat. And that is the reason why it didn't fire. So the correct answer to this is that this is a failure of the pacemaker, and the failure of the pacemaker is loss of sensing, the inability to sense this inherent beat. Okay, so let's move forward. All right, can you all hear me okay? There's some people that are saying that my voice is dragging. Can you all hear me okay? Can you all hear me okay? Yeah. All right. If you could not hear me okay, or you could not see my screen, some people are saying they can't see my screen. It's not on my end. It probably is on your end. Okay. All right. Let's discuss this particular ECG strip. And this is actually an ECG pattern that reflects the presence of an atrial pacemaker. So let's see, what are the characteristics of an atrial pace beat? Well, as you could see right over here where I'm pointing, you have again a pacing spike. And this pacing spike is followed by a P wave. And therefore, we know that this pacemaker is an atrial pacemaker. So again, in conclusion, the reason that we know that this is an atrial pacemaker is because of the fact that the pacing spike right over here is followed by a P wave. And therefore, this is an atrial pacemaker. This is different from a ventricular pacemaker because in a ventricular pacemaker, what we should have is a spike that is followed by a QRS complex. Okay, so let's move on to the next one. Okay, so some of you, or most of you, I should say, were able to identify that there is an abnormality in this ECG, and that is the ST segment being elevated. So let's determine or let's find out what is the significance of ST elevation. All right, I have a ruler here, and as you could see that there is going to be a measuring device that is going to establish what the baseline is. The baseline is the line that is after the P wave. So it's known as the PR segment right here. This is the baseline. So technically, the baseline should all be the same. Okay, should be in the same plane. And I don't know why it is writing erratically. So anyway, whenever you have an ECG, one of the things that you're going to try to look at is the ST segment. The ST segment is that segment or that part of the ECG that connects the S wave to the T wave. So in this particular instance, this is the ST segment where I'm pointing at right there. That's the ST segment. But the ST segment normally should be on the same plane as the PR segment, right over here. And as you could see, the ST is above the baseline. And so therefore, we're concerned about this. So what's the implication whenever you have an ST segment elevation? The implication is the possibility that there might be an ST elevation MI, or popularly known as SEMI. So this is an acute infarction. You obviously cannot diagnose an acute infarction based on just one lead. However, once we see this in the monitor, what we should do is we should obtain a 12-lead ECG in order to determine whether or not there is a presence of ST elevation MI. You cannot diagnose MI on the basis of just one lead. You have to have a 12-lead ECG in order to make sure that you are diagnosing the presence of STEMI accurately. Okay, so in this particular instance, we have a sinus rhythm, but there is an ST elevation that is an abnormality. And obviously, when you see this, it is going to be important that you obtain a 12-lead ECG. Now, I know that in the international arena where you practice, you probably need a physician's order to do a 12-lead ECG, correct? Now, here in the United States, in any area where a patient is monitored, you have the capability or the authority to perform a 12-lead ECG even without a physician's order. And this is important because in the presence of STEMI, you actually have 10 minutes to be able to diagnose the presence of STEMI so that early intervention could be undertaken. Okay, are there any questions as far as this is concerned? Jacqueline, if the voice is dragging all the time, what you could do is log out and then log back in again. All right. So there's nothing that I can do on my end if the voice is dragging on your end. It usually is having to do with your internet speed and connection. Okay, let's move on. Just get rid of this. All right, could you please type your answer in the chat box? What are your answers? Okay. So I like the answer that says missing QRS. So let's play it again. Oh, sorry about that. And make sure that you identify the missing QRS complex. Oh, Lord. Okay, as you could see in this slide, no. Sorry about that. Okay, as you could see, there are missing QRS complexes, meaning to say that there is a P wave without the QRS complex. Whenever we have a missing QRS complex, that means to say that there is an AV block. So I'm glad that a lot of you were able to identify that there is a presence of an AV block. Well, there are several types of AV blocks, and so let's review what those types are going to be. You have a blank screen at this time because I am going to talk a little bit about the types of AV block. There are three types of AV block. The first one is, of course, the first degree AV block. And a first degree AV block is characterized by a prolongation of the PR interval. And the PR interval normally is going to be 0.20 or less. But in a first degree AV block, there's going to be a PR interval that's going to be more than 0.20 seconds. And the PR intervals are all going to be the same. Another type of AV block is second degree AV block. And there are two types of second degree AV block. And the first one is called type 1 or Mobitz 1. They are the same. And it's also referred to as AV Wenckebach from the cardiologists that describe this phenomenon. And in a second degree AV block type 1, there is a gradual prolongation of the PR interval. And there's going to be eventually a P wave that is going to be non-conducted. So there's a gradual prolongation of the PR interval until such time that there is a P wave that is not going to be conducted. The other type of second degree AV block is Mobitz 2 or type 2. And in a type 2 AV block, this is going to be a much more serious condition because the blockage is going to be at the level of the bundle of His. And the characteristic of a type 2 second degree AV block is, again, there are P waves without QRS complexes, but the PR intervals are the same or are fixed. This is a dangerous rhythm because it could progress to the last type of AV block, which is complete heart block or third degree AV block. In a third degree AV block, there is variable PR intervals. There is no relationship between the P waves and the QRS complexes. And usually the rate or the ventricular rate is going to be very slow. So those are the three different AV blocks that we have at the present. And we identified this as a second degree AV block type 1. So why type 1? If you could see, here is the first PR interval. there's the second PR interval right there, and the third PR interval, and a P wave without a QRS complex. So we have a block right here, and looking at the characteristics of the PR intervals, the PR intervals are gradually prolonging. And therefore, this is what is known as a second-degree AV block type 1. Now, what is the implication of a second-degree AV block type 1? This is not a serious rhythm. It's benign. It usually is going to resolve itself. So whenever we see this particular rhythm, we need to make sure that we continue monitoring the patient because it could change to a second-degree AV block type 2. But second-degree AV block type 1 in and of itself is a benign rhythm. Okay. So I want to pause there to see if you have any questions as far as this discussion is concerned. Please indicate with a yes or a no if you have any questions or don't have any questions, so I know if I could proceed. All right, thank you. Let's go to the next one. All right, could you please type your answers? Okay, the correct answer here is a ventricular pacemaker with loss of capture. So it's letter A. So let's find out why that is. In the first place, we have a spike, and you know that the spike, as you could see over here, is followed by a QRS complex. So therefore, we have a ventricular pacemaker. However, we have a spike right over here. And as you could note, that there is no complex that follows this particular pacing spike. This therefore suggests that there is a loss of capture. So again, loss of capture means to say that there is an electrical current that was produced by the pacemaker. However, the musculature of the ventricles did not respond to that electrical stimuli. And this usually is because there is insufficient amount of electrical current that's being delivered. And therefore, in the event that you see frequent loss of capture, it needs to be reported to the physician because the amperage or the amount of electrical current that needs to be necessary to produce a response needs to be adjusted. So if it's a temporary pacemaker, we usually would increase the milliamperage. If it is a permanent pacemaker, then reprogramming of the pacemaker will be necessary to increase the amount of voltage that is going to be delivered to the ventricular musculature. Okay, let's go to the next one. All right, could you please indicate what your answer is on the chat box? All right, I only have 2 answers so far, and there's 27 of you. There are no options. Okay, so let's discuss. If we're looking at the rate, it actually is going to tell us that there is bradycardia. So you're correct in identifying that there is a bradycardia. However, when we take a look at the P waves, what do you notice about the P waves? Is it missing or is it inverted? We have an inverted P wave. So whenever we have an inversion of the P wave, we know that this is a P wave that is going to be produced by the AV node, and thus we call it a junctional rhythm. So let's review what a junctional rhythm is, because I think a lot of people forgot what that is. So let's say now that, just a minute. So if this is the sinus node, and this is the AV node, and the bundle of His and the bundle branches, the normal pattern is the sinus node will fire or initiate a complex, and therefore the impulses go in a anterograde fashion, meaning to say from top to bottom. And thus we have an inscription of waveforms that are going to be upright. However, in the case of a junctional beat, or a beat that comes from the AV node, what usually happens is this. If this is the AV node, the impulses are now going to be generated from here, and thus the impulse will go backwards, resulting in an inverted P wave. Or it could be right in the middle of the AV node, and this will result in a P wave that cannot be visualized, and therefore it leads to the second characteristic of junctional beats. So the first characteristic of a junctional beat is an inverted P wave before the QRS complex, such as what we have here. Or the second characteristic of a junctional beat is that there is no P wave that is visible. And the third one is that there's going to be a P wave after the QRS complex. So again, it's an inverted P wave after the QRS complex. So why is there an inverted P wave after the QRS? Well, if the junctional beat comes from below the AV node right here, it will activate the ventricles first and then activate the atria second, and that's resulting in an inverted P wave after the QRS complex. So those are the characteristics of beats that come from the AV node. In here, this is a manifestation that we have an inverted P wave before the QRS complex. Okay, so those are the 3 characteristics of junctional beats. And in this particular example, we have an inverted P wave before the QRS complex. I want to stop here to see if you have any questions so far, and I'll be glad to answer them. No questions? Okay, let's proceed. Okay, so the correct answer here is that it's a normal sinus rhythm with a 7-beat run of ventricular tachycardia. 7-beat run of ventricular tachycardia. Okay. So why is it a ventricular tachycardia? We said that more than 3 PVCs in a row is considered to be ventricular tachycardia. And such is what we have here. We have 1, 2, 3, 4, 5, 6, 7 beats of what appears to be wide QRS complexes. And we said that anytime we have wide QRS complex, this is a manifestation that it is going to be a beat that originated from the ventricles. And that is the reason why we would call this a ventricular tachycardia. So what do we do with ventricular tachycardia? Obviously, this is going to be a rhythm that is going to be of concern. And the reason why this is going to be of concern is because any ventricular tachycardia may reduce cardiac output. And therefore, if it reduces cardiac output, what's going to happen is that it might lead to cardiac arrest. Thus, in a situation like this, you would notify the provider. Most oftentimes when you work in an area where you monitor patients, you usually will have standing orders to give an anti-arrhythmic agent. So anti-arrhythmic agents might include amiodarone, or also lidocaine could be used, as well as procainamide. All right. So are there any questions as far as this is concerned? None? Okay, great. Just hold on. I need to readjust my screen over here. And let me see. Let me just stop sharing. Yeah, Michelin, amiodarone was very good for ventricular tachycardia. Amiodarone, lidocaine, or procainamide. All right, what is in front of you is a 12-lead ECG, and the question is, what is significant in this 12-lead? And we're going to share the results. This is how you answered. Some of you answered ventricular tachycardia. Some of you answered normal sinus rhythm with left bundle branch block. And some of you answered a ventricular pace rhythm. So let's go ahead and discuss why this, what the answer is. Well, this happens to be a ventricular pace rhythm. So let's take a look at it. Let me change the color of my pointer so you will see it. Do you see this spikes right here? Right there. And I think a lot of you, or some of you, didn't identify those pacing spikes. Okay? So that being the case, this is a ventricular pacemaker. You can see right over here that there is a ventricular pacemaker. And it is a manifestation of a normally functioning ventricular pacemaker. In other words, it's working well. Okay? So for those of you who haven't had the class on 12-lead ECG, which we're going to have next week, I'm going to just briefly discuss what we're seeing here as far as the 12-lead ECG is concerned. Whenever we look at a 12-lead ECG, we have 12 different views of the heart. And it usually is going to start with lead 1, lead 2, lead 3, AVR, AVL, AVF. And these are all what's called the limb leads. And the reason why they're called limb leads is because of the fact that the electrodes that are connected to the limbs or to the four extremities are the ones that would give you these views. And then we have V1 to V6, as you could see over here. They're also known as the precordial leads. That's because of the fact that they give you a view resulting from the application of electrodes into the anterior chest. And that is why it's called precordial leads. And usually whenever you have a 12-lead ECG, there's always going to be at the bottom a rhythm strip. And this will provide you with a continuous or a long rhythm strip that you could therefore interpret the particular rhythm of the patient. Okay, so this usually uses either lead 2 or V1 as the monitoring lead. In this particular instance, we have lead 2. Okay, so we'll discuss that more on 12-lead ECG whenever we're going to look at 12-lead ECGs. All right, so this is a ventricular pace rhythm. Any questions? Okay. All right, the correct answer here is it is an atrial and ventricular pacemaker. And an atrial and ventricular pacemaker, such as what is demonstrated here, is also known as an AV sequential pacemaker. So whenever the atrial pacemaker is activated, it also will continue it into the ventricles. And that is why it's called an AV sequential pacemaker. So in this particular situation, you have two electrodes, one electrode stimulating the atria and the other electrode stimulating the ventricles as well. This is what is known as an AV sequential pacemaker. All right, any questions? All right, for those of you who missed it, because some of you said ventricular pacemaker only, and some of you also answered atrial pacemaker only. If you take a look right over here, you have a pacing spike, and that pacing spike is followed by a P wave. So we know that there is a atrial pacemaker. At the same time, though, that there's also a spike right over here, which causes the QRS complex. And therefore, this also indicates that there is a presence of a ventricular pacemaker. Biventricular pacemaker, Michelin, is this the same as a CRTP? CRTP. I'm not familiar with the term, Michelin, so I don't know how to answer you. Or maybe my answer to you is I don't know. All right. Okay, are there any other questions? Okay, let's move on then. Oh, sorry. All right, could you please respond on the chat box, in the chat box? All right, a lot of you answered AU wave, and that is exactly the correct answer. So let's review. This is a P wave right here. This is a QRS complex. This is a T wave. And the one that follows it is a wave that is consistently following the T wave. And therefore, this is what we know as a U wave. Just as a review, a U wave may be normal or it could be abnormal. It becomes significant only if it measures 2 millimeters or more. And if that is the case, then this is a manifestation of hypokalemia. So if you see this in the monitor, you need to make sure that you correlate the finding and by checking on the serum electrolytes, in particular, to determine if the potassium level is abnormal. So that's the significance of a pathologic U wave. So remember now that a pathologic U wave or a U wave becomes abnormal if it is going to be 2 millimeters or more. So in this particular instance, it only is 1 millimeter in height, and therefore this is going to be a normal U wave. All right, your answers, please. Is this your final answer? Okay, so let's see. This is how you responded. A lot of you said a ventricular pacemaker with loss of capture. Some of you said ventricular pacemaker with loss of capture and sensing. The correct answer is it's both loss of capture and sensing. So let's see and discuss why that is. Okay, so let's do this. All right, so we have a spacing spike right here. And in some instances, what happens is that, oops. And let me play it again. All right, what we have here is intermittent loss of capture as well as intermittent loss of sensing. And I'm trying to play it, and unfortunately, it will not go back to where I want it to be. But here is a good demonstration right here. As you could see, there is a pacing spike without any QRS complex. This is what's called loss of capture. Now, what is this beat right here? This beat right here is a normal QRS complex, which means to say that it's an inherent ventricular beat. Yet, the pacemaker fired right here, which means to say that it did not detect this QRS complex. So therefore, there's both loss of sensing as well as loss of capture. Okay? So with that in mind, are there any questions as far as that is concerned? Loss of sensing and loss of capture. Clear? Okay. How about the others? Great. Let's move on. Oops. All right, please indicate your responses on the chat box. Okay, the correct answer here is there is a sinus pause, and this sinus pause is due to a sinus arrest. So let's review what a sinus pause is. Now, sinus pause is a situation wherein the sinus node becomes incompetent in regularly discharging or initiating an electrical impulse. How do we detect the presence of a sinus pause? Well, as you could see over here, and I'm going to bring back my caliper, there is a regular pattern or rhythm that is established by the P wave in here. As you could see, it's regular, and all of a sudden, there's no more P wave right there. Okay? So therefore, there is a lack of a P wave right over in this situation. And because there is a temporary cessation of an electrical impulse coming from the atria, we call this a sinus pause. But there are two causes of sinus pause. One is what's called a sinus arrest. This means to say that the sinus node just completely shuts out. And the second reason why we might have a sinus pause is what is known as a sinus exit block. In a sinus exit block, what happens is that the sinus node still continues to work, but the problem is that the impulse cannot get out of the sinus node itself. So let's illustrate again what I'm talking about. What I'm talking about here is that in the situation of a sinus exit block, what happens is that the sinus fires, but because this particular impulse might be going out through a thickened area of the sinus node, it is unable to get out. And this is what's called a sinus exit block. Remember now that in a sinus exit block, the sinus node continuously works. However, there are some instances wherein the impulse is blocked from getting out of the sinus node. In a sinus arrest, the sinus node just decides to stop. And that's exactly the description of what is known as a sinus arrest. So how do we determine if the pause is due to a sinus arrest or to a sinus exit block? If the rhythm is maintained, and that means to say that this P wave and this P wave interval right over here, it's going to be the same after the pause, then we know that the sinus node continued working. However, in this particular instance, as you could see, there is a reset of the heart rate. The heart rate is no longer the same. This is the heart rate before the pause. This is the heart rate after the pause. So as you could see, there has been a reset, and therefore we know that this is a sinus arrest. Okay, so this is a little bit complicated. So I wanted to make sure that if you have any questions, to please raise it right now. Is that clear? Do you have any questions as far as the difference between sinus arrest and sinus exit block? Okay, so let me just write down, therefore, the differences between the sinus arrest and sinus exit block. So in a sinus arrest, oops. All right. Okay, so the major differentiation of the two, therefore, is in sinus arrest, the rate before and after the pause differs. In sinus exit block, the rate before and after the pause is the same. So in looking back now to this particular example, we see that the rate before the pause, right here, is different from the rate after the pause. And therefore, this is what is known as a sinus arrest. Okay? Is that okay now, Margaret? Is that clearer? All right. So whenever you see a pause, what you need to do is to look at the rate before the pause and then compare it to the rate after the pause. If they're the same, this will be a sinus exit block. If they're different, however, then this means to say that this is a sinus arrest. And this is exactly what is demonstrated in this particular strip. All right, any questions? Great, let's go on and move forward. All right, and what do you think is the problem here? Could you please indicate in your chat box? Okay. Correct. Everybody is correct. Well, this is a ventricular tachycardia, also known as, and I mean, it's the type that is called polymorphic ventricular tachycardia, better known as torsades de pointe. And torsades de pointe is a French term which means of different heights or of different points. This is exactly what is noted over here. As you could see, The points are sometimes going down, sometimes it's going up, and therefore they're going in different directions. This is what is known as torsades de point. So in torsades de point, it being a form of ventricular tachycardia, we have to make sure that we treat this individual right away. And torsades de point is a condition or a form of ventricular tachycardia that oftentimes is associated with hypomagnesemia. So one of the major things that we ought to remember is that this particular problem, therefore, could be reversed by the administration of magnesium. And magnesium usually is given as 2 grams, 1 to 2 gram bolus. And this usually is going to be effective in terminating it. However, when the patient or if the patient goes unconscious, should you defibrillate this patient or should you cardiovert this patient? What is the treatment for torsades de point if electrical termination is indicated? Is it defibrillation or cardioversion? Your response, please. Okay. Well, if it's torsades de point, you need to defibrillate. It's not going to be cardioversion. In this type of ventricular tachycardia, it's got to be defibrillation. Why is that? Okay, let's discuss why that is. The reason why we do not cardiovert is because of the fact that when you cardiovert, remember that cardioversion detects the QRS complexes. Cardioversion is not going to be possible in this situation because of the polymorphic characteristics of the QRS complex. Sometimes it would sense this, sometimes it would not sense this because the QRS are pointing at a different direction. And that is why, remember this, in this form of ventricular tachycardia, you do not cardiovert, you defibrillate, because if you put the machine on cardioversion mode, it will not be able to detect the QRS complex consistently. And therefore, the appropriate treatment for torsades de point is going to be defibrillation. Okay? Any questions as far as this is concerned? Great. So remember that in ACLS, in ventricular tachycardia, monomorphic, it is going to be cardioversion, but in torsades de point or polymorphic ventricular tachycardia, it would have to be defibrillation. All right, great, thank you. Next. All right, could you please respond in the chat box? Okay, so we have variable responses. We have a second degree AV block, and some of you said first degree AV block. Okay, so let's analyze. When we look at this ECG strip, one concern that we have is going to be that there is or there are P waves without QRS complexes. So right over here is going to be one, right? There's going to be this one as well. And it looks like there are many P waves without a QRS complex. So when we have a P wave without a QRS complex, we always know that there is an AV block. Now, it could not be a first degree AV block because in first degree AV block, remember now that all P waves are supposed to have a QRS complex. The only thing is that there is a prolongation of the PR interval. But in here, we have a consistent PR interval. So if we measure the PR intervals, and I'm going to illustrate that again with our measuring device here, we could see that the PR intervals remain the same. Okay, so that's the PR interval here. It's the same PR interval here, and it's the same PR interval here and here. So therefore, there is a consistent PR interval. And a consistent PR interval, therefore, is going to mean that this AV block is going to be Mobitz type 2. So the correct response is letter B, a second degree AV block type 2. Okay? All right. Are there any questions as far as this one is concerned? Chat, yes or no? None? Okay, great. All right. What is your interpretation? Your interpretation, please put it in the chat box. All right. We have a rate of 81 or 80, and it appears that all the complexes are normal. There's a P wave, there's a QRS complex, and there's a T wave, all in normal fashion. And therefore, this is a normal sinus rhythm. I just needed to put that up just in case you forgot what normal sinus rhythm is. All right, let's go to the next one. All right, could you please type your responses? Okay, thank you. Let's go ahead and see what the correct response is. So we all agree that there is a P wave without a QRS complex, and that is this one. So we know that this is going to be a block. Now, if we take a look at the P waves right over here, and the PR intervals, I should say, we notice that there is a gradual prolongation of this PR interval. See, it becomes longer, and therefore this is a manifestation of a second degree AV block type 1. Remember now that in sinus arrest or a sinus pause, there's not going to be any abnormality in the PR interval. Over here, we have a pattern whereby the PR intervals are gradually prolonging. And therefore, this is a characteristic of a second degree AV block, Mobitz 1, also known as AV Wenckebach. All right, for those of you who did not get it correctly, do you have any questions pertaining to this slide? None? Okay, let's move on then. Mic test, mic test. Can you hear me? Okay, thank you. All right, so a lot of you said VTAC, some of you said multifocal PVCs, triplet PVCs, and ventricular trigeminy. All right, so let's take a look at what the correct response is. We have a repeating pattern over here, wherein we have one PVC is what we call or one type of PVC is what's called unifocal PVCs. Two PVCs in a row is what's called paired PVC or couplet PVC. Three PVCs in a row is what is known as a triplet. Okay, so if it is every third beat, that's called trigeminy, but three PVCs in a row is what is known as a triplet. So in this particular example, the correct answer is we have a normal sinus rhythm with triplets, meaning to say that there are three PVCs in a row. Now, what is the implication of a triplet? Is this dangerous? And the answer to that is yes, it is dangerous. And therefore, it requires intervention. So if you have a standing order to treat PVCs that are frequent or are going to be in salvos or in rows, such as this, then you would have to intervene appropriately. So usually we would give amiodarone or perhaps lidocaine, or as an option, procainamide. Okay? Let's move on. Okay, so a lot of you responded as letter B, which is a bundle branch block. That's the correct answer. This is not ventricular tachycardia
Wow.
because,
May nawala ka?
hold on, let me just mute everybody. Okay. In ventricular tachycardia, you would not have a P wave that is going to be consistently causing a QRS complex. Right atrial hypertrophy would be manifested by a P wave that is abnormal. And a third-degree AV block would have a P wave or P waves without QRS complexes. So it leads us to the correct answer, which is a bundle branch block. So how did we know that this is a bundle branch block? Well, we knew that this is a bundle branch block because there's an abnormality of the QRS complex. And the abnormality is that the QRS complex is going to be 0.12 or greater. A normal QRS complex should be less than 0.12. So let's examine this QRS complex to see how wide it is. As you could see, it is 1 box, 2 box, and 3 boxes. 3 boxes is 0.12 seconds, and therefore this is going to be an abnormality. Now, a lot of you might ask the question, is this a right bundle branch block or a left bundle branch block? And the correct answer is, looking at this particular strip, we will not know which bundle branch is going to be the problem. And the reason is that in order for us to be able to identify which bundle branch is going to be the problem, is that we need to have a 12-lead ECG. We can identify which bundle branch block it is by looking at lead V1. In the absence of lead V1, you should not claim that it is a left bundle or a right bundle branch block. Okay? And we're going to cover that in our discussion of 12-lead ECG, and that will be next week. Are there any questions as far as this strip is concerned? Either say yes or no so that we can move on. Okay, thank you. All right, please indicate your responses on the chat box. Okay, so it looks like a lot of you were able to identify the abnormality over here. There are 2 abnormalities. One is going to be the ST segment, and the other one is the presence of a PVC. But let's go look further. The rate of this particular strip is that it looks like there's going to be a rate of 100, so that's normal sinus rhythm. But in inspecting the ST segment, I should say, we note that this is above the baseline. And again, the baseline is right over here, or right there, but the ST segment is right over here, which therefore is a manifestation that there could be semi, right? And the second observation that we see over here is that there is a PVC, and this PVC, or the premature ventricular contraction, is very close to the T wave or on the T wave itself. And this is going to be something that we're going to be concerned about. Now, in just looking at this, if this is one PVC that you saw, would you be concerned with this PVC? Yes or no? Could you please type on the chat box whether or not you will be concerned? Or would you ignore it? Yes or no? Okay, so a lot of you said that you would be concerned. And so let's see why you are concerned. And I'm going to, again, you have a blank screen because I'm going to illustrate something. Now, whenever you have PVCs, you always have to evaluate it based on its proximity to the T wave. Hold on one moment. So if this were the T wave, any response or any abnormalities, such as a premature beat occurring on the first third of the T wave, is going to be very dangerous. This area of the T wave is what is known as the vulnerable period. And therefore, any PVCs that would occur during this time is going to have a potential of leading to cardiac arrest. So if you have a PVCs and this is the T wave and there's a PVC right here, this is away from the T wave. But if the PVC occurs right on the first third of the T wave, we're gonna be concerned about it. We're going to be concerned about it because of the fact that it has the potential of leading the patient into ventricular fibrillation and cardiac arrest. Such is what happened over here. And as you could see, I'm now enlarging it. It happened right on the T wave. This is the T wave right there, and it just occurred right on it. And therefore, this is a dangerous situation. So the correct answer is going to be a PVC that is right on the T wave, letter B. Okay. All right, let's move on. Okay, so we have a rhythm that is interrupted sometimes by the occurrence of a premature beat. And you could hear it actually. So for those of you who work in monitored situations, you could hear the premature beat as illustrated here. Let's see. Oops. So this is the premature beat, and this is a PAC. And the reason why it's a PAC is because there is a P wave before the premature beat, or before the QRS complex, I should say. And therefore, the premature beat is coming from the atria, and therefore we call this a PAC. What is the significance of a PAC? Is it going to cause hemodynamic instability? And the answer to that is not necessary. However, frequent PACs usually is a precursor or is a sign that the patient might be on congestive heart failure. So when you see a lot of PACs, what you need to do is to make sure that you check on the patient's lungs, auscultate the patient's lungs, and try to determine if there are any other signs and symptoms that reflects the presence of congestive heart failure. Okay, great. And so let's go to the last one right here before we go on our quiz. All right. What is your answer? Okay, a lot of you or all of you answered letter A, which is actually the correct response. It is a second degree AV block type 1. And let's try to identify or discuss why that is. And so let's see, we have a P wave right. Oops. We have a P wave right over here without the QRS complex. So we have a block. And we said that anytime we have a block, we should always look at the characteristics of the PR interval. So when you look at this PR interval and this PR interval, we notice that it is gradually prolonging. So let me illustrate that again. Here's the first PR interval. There's the second PR interval. There's the third PR interval. And this is the fourth PR interval. So it's gradually prolonging. This is the characteristic of a second degree AV block type 1. Okay? All right. So I'm going to stop sharing right now because what we're going to do is we're going to have an exercise and we're going to play Kahoot. All right. So let me just tell you a little bit about Kahoot. As I said earlier, Kahoot is a game, and this is going to be made possible by you using your telephone. And so what I'd like for you to do is using your phone, you're going to go into kahoot.it, kahoot.it. And what you're going to do is you're going to follow the instructions that is going to be on the screen. And I'm going to share that with you right now. All right, you're going to enter the PIN number 394977 and then follow the prompts. If you don't have the ability to join with your phone, you can just watch on the screen and play along on the chat. All right. For those of you who are still joining, remember now, go to kahoot.it. After you have gone to kahoot.it, you enter this game pin and follow the prompts. It will ask for your nickname and you're in. Okay, so the object of the game is for you to answer as quickly as possible using your telephone. The options will be color-coded, and so you need to watch the monitor to determine or to see what the options are. So let's try the first one. Okay, so this is a PVC right on the T wave. And as I had mentioned earlier, this is a very, very dangerous type of PVC. So despite the fact that it's going to be infrequent, we're going to intervene. And usually what's going to be the intervention will be the administration of an anti-arrhythmic agent. So the correct response, therefore, is true. So let's see who the fastest one was. And Roland was the fastest one to respond, followed by Eric, April, Joe, and Vince. Congratulations. Okay, so let's see. There's a wide variability in your responses. We have a rhythm that is fast, and the QRS complex are narrow. So this is what's known as a supraventricular tachycardia, or SVT, also known as PAT, or paroxysmal atrial tachycardia. So the question was, what would you do if the patient is asymptomatic? Well, we know that when patients are going to be asymptomatic, we begin with non-interventional or non-invasive interventions, first of all. And in this particular instance, what we would do is to do vagal maneuvers. So there are several ways in which we could activate the vagus nerve. One of them is holding the breath, also known as Valsalva maneuver. The other thing is we could actually do the same thing by massaging our eyeballs, because massaging the eyeballs or pressing on the eyeballs itself will cause the activation of the vagus nerve, and this is going to therefore be effective in terminating the tachycardia. Other interventions for SVT include immersing the face on water. What do you usually do if you're underwater? You hold your breath. So in essence, you're doing Valsalva maneuver. We only do cardioversion or adenosine in cases wherein the patient becomes symptomatic. So in this particular instance, we would intervene first with non-invasive interventions, which would include, again, vagal maneuvers. And there are several ways in which we could activate the vagus nerve. One, holding the breath, coughing, or maybe immersing the face under water, or orbital pressure, all could do the same thing. Okay? So that is the correct answer. And let's see who responded to it. There's only one who got that correctly, and that is going to be Roland. Very good. Thank you. Okay, the correct response over here is going to be defibrillation, because remember, this is torsades the point, and torsades the point. If we need to do electrical maneuvers or interventions, what we have to do is to defibrillate. Excellent. So let's see who the fastest one: Eric, Meg, April, Vince, and Joe. Congratulations. Curry, the access code is on the screen, 394977. Okay, so let's take a look at this ECG. There's something that's abnormal in the ECG in the sense that the T wave overpowers the height of the R wave. Remember now that when we have a tall T wave, this is a manifestation of an electrical abnormality, such as hyperkalemia. So let's define what tall is. Normally, the T wave should not exceed 1/2 of the height of the R wave. In this particular situation, as you could see, the T wave exceeds 50% of the height of the R wave. And therefore, we classify this as a tall T wave. Tall T wave is the manifestation of hyperkalemia. And 9 of you got this correctly, so that's great. And so let's see who was the fastest. Eric, Meg is the highest responder with a streak of 3 correct answers in a row. Pau, Joe, and Vince. Okay, so let's see what this is. As you could see, there are P waves that are coming regularly, and there's one P wave that occurs prematurely. So this is a PAC, but there's no QRS complex following that P wave, and therefore we call that a non-conducted PAC. Non-conducted because the atrial impulse was not conducted through the ventricles, and therefore we call this a non-conducted PAC. So let's see, 3 of you got that correctly, so that's great. And they are Eric, Joe, Meg, Eileen, and Eileen has the highest streak of 3, and Pau also is in the roll. Okay, so only got one got it correctly, but anyway, a lot of you answered that there is an MI. Oh, let me go back to that one. Sorry. I wanted to discuss that a little bit. So for those of you who haven't attended 12-lead ECG in the past, please attend next week. But anyway, we have evidences of here of ST elevations. And the ST elevations are in V1, V2, V3, V4, and these are the areas called the anteroseptal area of the heart. So this is an anteroseptal MI. This was just plug in to see if you, for those of you who had attended the 12-lead ECG, if you remembered that information. Okay, so that's an anteroseptal MI again. And the reason is we have ST elevations in V1, V2, V3, V4. And these are called the anteroseptal areas of the heart. Okay, so let's see who got that correctly. Oh. Okay, again, I didn't expect all of you to answer this correctly, but this is just as a review for those of you who had attended the 12-lead ECG in the past. We have ST elevation in lead 1. We have ST elevation in AVL. These are the lateral leads. V1, V2, V3, V4, V5, and V6. These are all anteroseptal and lateral leads. So that is why we have the lateral, the anterior, and the septal areas that are infarcted. So let's see who got that correctly. Eileen again, and Joe, Pau, April, and Eric. Congratulations. All right, let's take a look at it. We have an irregular rhythm, and this irregular rhythm has a wavy baseline and a non-identifiable P wave. So these are all characteristics of an arrhythmia called atrial fibrillation. In fact, second to normal sinus rhythm, atrial fib is the most common rhythm you will see. Okay, so first is going to be sinus rhythm. The second very common rhythm that you will see in the monitor is going to be atrial fibrillation. And it's characterized by 1, irregular heart rate or irregular rhythm. Second, a wavy baseline. Third, a non-identifiable P wave. So this is clearly atrial fib. And because the rate is between 60 to 100, we call this a controlled atrial fib. If the heart rate is greater than 100, then we call this an uncontrolled atrial fib. Okay, so let's see. There's one of you who got this correctly, and a lot of you said atrial fib, which was also correct, but not complete. Eileen, congratulations. Okay, the correct answer is that there's ventricular pacemaker with loss of sensing. There's a spike right over here, but it didn't detect this QRS complex right over here. And therefore, the problem is loss of sensing. And let's see who answered that the quickest. Pau, Eileen, Joe, April, and Eric. And let's go to the last one. Okay, so we have an AV block as evidenced by P waves without any QRS complexes. And the PR intervals are all variable. As you could see, this is long, this is short, this is very long, and so on. And therefore, there's no association between the P waves and the QRS complexes. These are manifestations of third-degree AV block or complete heart block. And I'm glad that 4 of you answered this correctly. Again, for those of you who missed it, remember now that in a third-degree AV block, the PR intervals are all variable, such as what is demonstrated in this particular strip. Okay? So let's see how you all did. The third place is April. Congratulations, April. And in second place, Al. Congratulations. And first place is Eileen. Congratulations. And runners up, Eric and Joe. All right, so once again, it is my pleasure to have had this 2 hours with you. And I look forward to having you join me in the next webinar next week, which would be on 12-lead ECG. My name again is Dr. Tom Madayag, and I will be online for the next 20 minutes or so after the conclusion of this webinar to answer any questions that we might have missed or you did not raise during the presentation. So I want to wish everyone a good night, a good evening, or good day wherever you are. Thank you once again.